Assalamualaikum and good afternoon, everyone. Thank you for joining us for the second webinar of Neuroemergency SIG for this year. So today we have two distinguished speakers with us, and I'm so happy to introduce my colleague, Dr. Hafiza Ciani. She's my batchmate when we were doing our master's program, and she's currently working in Hospital Sungai Petani, Kedah. She's one of the pioneer in facilitating the stroke thrombolytic therapy in her center. So without further ado, I would like to welcome Dr. Hafiza to become the moderator of the day. Thank you.
Okay, thank you, Dr. Nina, for your kind introduction. Assalamualaikum and a very good afternoon. Welcome to our monthly Neuroemergency CME class by Neuroemergency Special Interest Group. Okay, I think Dr. Nina already introduced me. I'm Dr. Hafiza, emergency physician from Hospital Dr. Halim Sungai Petani, Kedah. For today, we have two lectures. First lecture will be given by Associate Professor Dr. Kamarul Aryffin Baharuddin, title of Approach to Limb Weakness, followed by lecture by Dr. Fu Leong, title Peripheral Property, What ED Personnel Should Know. Each lecture duration is about an hour, including question and answer session. Before we start with our first lecture, let me introduce to our first speaker. He is my beloved teacher during my undergraduate and also postgraduate study, Dr. Kamarul Aryffin. He's an associate professor in emergency medicine and also consultant emergency physician at the HUSM Bangkreang, Kelantan. He was born in Penang and settled down in Kelantan. He graduated from USM for his postgraduate emergency medicine training in 2006. His area of interest is neurological emergency and also pain management in emergency medicine. He's currently also a deputy dean of academic career and for the School of Medical Sciences of USM. I think without any further ado, I would like to invite our first speaker, Prof Kamarul Aryffin. Prof, the floor is yours. Thank you.
Okay, thank you, Dr. Hafiza. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And good afternoon, everyone. Sorry for a bit rushing today. I just finished my meeting just now. Good afternoon also to Dr. Hugh, the one of the neurologists who will be the speaker for today. So my name is Dr. Kamarul. I'm going to share with you about the approach towards lower limb weakness. So we have here we have two speakers today. I would like to thank to the Neuroemergency Special Interest Group from under the College of Emergency Medicine for inviting me. And I also feel lucky today because Dr. Hugh is with us. Should you have any question, we can pass over to Dr. Hugh to answer the question.
Hi, Prof Kamarul. Nice to meet you. Nice to meet you.
Nice to meet you.
Good afternoon and nice to meet you. Yeah.
Okay.
You go ahead first. You go ahead first. Yeah.
Okay. All right. Sure. No. All right. So if you notice here, actually, neurophobia, actually a fear of neuroscience. I think this is good because this initiative to have this emergency medicine SIG is very good initiative because we know that many people have some kind of neurophobia, a fear of the neurosciences and clinical neurology. Yeah? So this is very true. This is the latest article last year about the systemic review of the English, Spanish and Portuguese literatures about the level of knowledge, level of confidence, and level of interest. Of course, we see that there is lowest level of knowledge, least confidence, but somehow when come to the level of interest, actually the results vary. Some studies reported that neurology was rated as one of the most interesting subjects by medical students and non-neurology residents. So I have to agree with this study that actually it's difficult, but yet it's very one of the most interesting subject. So the reasons for neurology being perceived as difficult subjects because we have insufficient teaching of basic neuroanatomy, neurophysiology, and of course our neurological examination. We don't really confident enough with our method of examinations. And if you're talking about the diagnosis and little opportunity to work with neurologists, I have to agree with that. But to me, being a emergency medicine, diagnose is second thing. But if you are able to localize, that is the most important part. If you're able to localize where the lesion is, so that is more important rather than a diagnosis. And of course, when we talk about emergency as emergency medicine, we have already talk about the airway, breathing, and circulation. So as long as we can manage the airway well, airway, breathing, and circulations, the D part will be slightly later. And of course, the final diagnosis is a bit later, but as long as we can come to the proper clinical neuroanatomical localization will be much better. So actually, I myself has this kind of thought to introduce a kind of a class of neurology, neurological emergency class. I put the X mark at master because this is not a master class. This is just a class by non-neurologists where the concept is peer-to-peer learning. So where we emergency residents can sit down, we have a platform, have a class where we can sit down, discuss about the technique of examination, discuss about the localizations among us, because actually we have some knowledge somehow, but we feel, of course, we don't feel much confidence, but we should sit down and discuss among us before we go for the real one, the master class of neurology. For your information, every time MSN organize scientific meeting, they will have this, what we call it, they call it pre-conference workshop on neurology masterclass. I used to attend all these neurology masterclass, register myself. This is in 2019 prior to the COVID. And during this COVID, of course, there are no neurology masterclass. But I think if you want to go further, then you can attend this neurology masterclass. But for emergency medicine residents, to have a platform where we sit down, peer-to-peer learning with the concept of peer-to-peer learning, I think this is also equally important. Okay, when we talk about these neurologic patients, of course, we will, the first thing that we should ask is where is the lesion? And our approach is through the anatomic perspective, neuroanatomic perspective, followed by the physiologic and etiology. And of course, we have to localize the lesion. So localization of the lesion actually happen in any system, cardiovascular, respiratory, but the difficulty to localize the lesion is not complicated as in neurology. So that's why most of the time when patient come with the shortness of breath, so we focus on the cardiorespiratory, even though neurology cause can be part of it, but most of the time it's under the cardiorespiratory. Actually, we already localized where the lesion is. But what's come to neurology, it can be from head to toe. So that is the most challenging part. So why we need to localize these lesions? Because first we want to avoid over investigation. We know that it has happened before this, and it is keep on happening. Any patient come with the lower limb weakness, the first thing that come to our mind is CT scan of the brain. It's like a knee jerk, which is not correct. So we should localize first, because we're talking about peripheral neuropathy. Definitely CT scan does not give us any clue. In fact, it can mislead us to another things. We should know the limitation of certain investigations and definite diagnosis, and because this will lead us to the definite diagnosis, and of course, this definite diagnosis will lead to different treatment and prognosis. All right, how many lesions are there in the nervous system? So general rule, there is only one lesion to best explain all the neurological signs. Only when there is really not possible, a second lesion should be considered. Again, when we talk about localization, we cannot run from the history taking. Studies have shown that we emergency medicine doctors are the worst doctors in taking the history. that is understood because our we have all emergency cases. Our focus is we should have targeted physical examination, and that is our nature. But I know patients presentations, undifferentiated presentation. So we should be try to have blend. We have to blend to take the proper history localizations. All right. So this is a bit revision for morphology. There are cranial nerve motor system examinations, sensory system examinations, cerebellar, skull and spine, meningocele and meningeal. When we talk about lower limb weakness, of course, we focus more on motor system examination. The component is TPR, tone, power, and reflex. This is a table that I prepared, of course, with the different notes and readings. Localization in neurological emergency. So we can see here, actually, we can divide it into the red color is the upper motor neuron, roughly. The blue color is the lower motor neuron. So there are about 10 sites, neuroanatomic localization, for us to come to the diagnosis. So these are the 10 sites for the any neurological emergency, with what are the possible etiology, what kind location, what type of weakness. This is more to like a clinical localization, cranial nerve involvement, sensory, tone, muscle wasting, reflexes, circulation, and involvement of the bladder, bladder paralysis. When we talk about lower limb weakness, of course, we are talking more to spinal cord. And of course, we are talking more to the lower motor neuron, where anterior horn, nerve root, peripheral nerve, neuromuscular junction, and muscle should be the site of the lower limb weakness. Of course, contact can also happen when there is normal brachiocephalus, but we focus on this condition only. So that was the beginning of my presentation. So that was the introduction. So let's start with something that we already know. Something that we already know for neurology, that we know that upper motor neuron lesion, lower motor neuron lesions. So spasticity, hypertonia, hyperreflexia, Babinski clonus are the features of upper motor neuron lesion. Lower motor neuron lesions, muscle wasting, fasciculation, hypotonia, hyporeflexia, plantar downpoint. All right. Then this, if we go slightly detail, we know that sensory level on the trunk is refers to spinal cord lesions. Bladder dysfunction also refers to like a spinal cord lesions. Cross signs in brainstem, facial weakness, brain, hemiparesis, also brain. For low motor, when there is features of sensory involvement, sensory symptom and signs, usually is a peripheral nerve. Reflexes decrease is peripheral nerve. Proximal weakness, muscle or neuromuscular junction. Fasciculation, anterior horn cells, a combination of upper motor and lower is a motor neuron disease, amyotrophic lateral sclerosis. So this is roughly that maybe we have some knowledge about it. So let's go towards the topic, the main of the topic about the approach towards lower limb weakness. So when we talk about approach, this approach, actually I took this one from the emergency neurological life support. This course was introduced many years back by the Mayo Clinic team. This is one of the good courses that we emergency medicine residents should consider to take. It's all online, but of course the fee is more than 1,000 ringgit. So in general, they divide approach towards lower limb weakness into these three things. Basically, we should assess the ventilation, what are the etiologies, and we have to localize. So of course, when we talk about muscle weakness, even though we're talking about lower limb, please remember it may also, when we talk about, even talk about the limb, it may also involve the respiratory muscle as well. So do we need to intubate this kind of patients? They may come with a shortness of breath. Now, of course, we have to look for the etiologies and localization. We want to come to the diagnosis, determine the diagnosis. All right, but remember, because we are in emergency medicine, we cannot run away from trauma. So acute traumatic weakness may also occur, like spinal cord, acute spinal cord injury. So is there any difference between the acute spinal cord injury and any spinal cord lesions? And of course, the first priority is always about the airway and breathing. So do we need to intubate? So these factors to be considered for intubation because it involves the neuromuscular respiratory failure. So is the patient in respiratory distress? We know by the rapid shallow breathing, any paradoxical respirations, any difficulty in swallowing, whether there's coughing or choking after the swallowing, symptoms of bulbar muscle weakness, at risk of aspiration, if possible, is it any drowning in the secretions, interrupted speech, nasal voice, and mushy dysarthria speech or dysphonia, evidence of hypercarbia. So when there's hypercarbia by ABG, so it indicates that alveolar hypoventilation. So this is the first to happen rather than the hypoxia. So hypoxia is slightly later, usually related to atelectasis or pneumonia, and any exposure to toxins or insecticides. This, based on the anatomic localization that may lead to neuromuscular respiratory failure, spinal cord lesion, yes, if higher spinal cord, it may lead to neuromuscular respiratory failure. If slightly lower, so it does not affect the respiratory muscles. Motor neuron disease, peripheral nerve disease like Guillain-Barré, CIDP. So this topic will be covered by Dr. Hugh after this. Neuromuscular junction lesion, MG, myasthenia gravis, opioid organophosphate poisoning, so and botulism, and any muscle lesion. So these are the things that can be the anatomic localization for any condition that lead to neuromuscular respiratory failure. All right, so one of the cause just now, we know that when we talk about localization just now, we're talking about the spinal cord. But if we go by the etiology, so there are a few conditions. We know when there is any hemiparesis, it usually refers to the usually stroke. Any CNS infection, patient may come with seizures or status epilepticus, spinal cord, electrolytes, hypoglycemia also may lead to weakness. But let's start with the spinal cord first. So since this ENLS, we talk about the acute spinal cord ischemia, like aortic dissection. So maybe we can talk a bit after this about the aortic dissection. But let's go to this table again. This table tells us that when spinal cord is involved, we should expect the features of upper motor neuron. So it can be paraplegia. Of course, higher spinal cord may lead to quadriplegia. So the example of etiology can be any tumor, transverse myelitis. It can be complete or incomplete spinal cord injury, or can be intramedullary versus extramedullary, conus medullaris, caudate echina. Actually, caudate echina is not a spinal cord disease, but because it's in the spinal cavity, so it's considered part of the spinal cord. Always the books put the caudate echina is part of it. Of course, the features is different. Location of the weakness depends, but usually if low part, it can be paraplegia. Cranial nerve involvement, no. This is the red one to tell that this is like a hallmark sign. Sensory level to tell you that, yeah, this is spinal cord lesions. So tone increase, hypertonia, except in spinal shock, become flaccid paralysis. Muscle wasting, non-muscle wasting, reflexes of course increase, fasciculation none, and bladder paralysis is present. So before we go for the case for this type of spinal cord lesion, let's go first for the spinal cord ischemia, secondary to aortic dissection. Because actually, when I Google through, there are actually quite a number of case reports, and luckily they have made the literature review for all the cases that had presented with spinal cord syndrome following the aortic dissection. It happened more in males above 55 years old. pain only found in 50% of them. Okay, anterior cord syndrome is the top of the presentation, where there is permanent and hypertension is the most common risk factors. So you can see here, this is summary of the literature review by the authors. We can see here that, of course, most of the patients presented with a symmetrical presentation, but asymmetrical may also happen. And pain, okay, some of the patient has no pain. Most, it's like 50-50. All right, and they are all 67 case report. Follow aortic dissection, acute spinal cord syndrome followed by the aortic dissections. So it's not uncommon to have this kind of presentations. All right, so let's go back to this spinal cord lesion we talked about just now. So I give you a scenario that a patient had came to the ED a few years back, a 50-year-old gentleman, past history of pulmonary tuberculosis, presented with bilateral lower limb weakness, for 1 week duration, brought in by the family members. Patient was on the wheelchair. No history of fever, however, there is history of constitutional symptoms, loss of appetite, loss of weight, and thoracolumbar X-ray was done. It was normal. Okay, the reason it was done because we are thinking whether there is a TB spine as well, because he has past history of pulmonary tuberculosis and he has these positional symptoms. Otherwise, for the finding, yes, he has paraplegia. There was no cranial nerve involvement. Sensory level, yes, at the T8. Hypertonia, hyperreflexia, no muscle wasting. Fasciculation, no fasciculation, and bladder paralysis. When we talk about bladder paralysis, we always talk about the incontinence, which is actually involuntary leakage of urine. Actually, when we talk about spinal cord disease, spinal cord lesion, stress urinary incontinence or overflow urinary incontinence occurs basically in the absence of a bladder contraction, and is due to inadequate ureteral sphincter function. But having said that, actually maybe the earliest sign can be urgency, a sudden and compelling desire to pass urine that's difficult to differ. So actually, what other question that rather than asking the patient ada terkencing ke, ada terberak ke, so you should ask also about the urgency, because this can be the earlier features rather than full-blown incontinence. Urgency meaning that patient cannot hold when he feel that he want to pass urine, he must go to the toilet immediately. So this can be the early symptom rather than just now the full-blown of incontinence. So of course we did we admit this patient, and MRI was planned a day later. So it turned out to be transverse myelitis, possible TB. All right. So this just now we talk about non-traumatic. Now when we talk about acute traumatic spinal cord injury, remember this patient has this spinal shock characteristic. There is a flaccid paralysis. So we don't see any hypertonia, we don't see any hyperreflexia. In fact, Babinski will be absent. So other than that, we will see loss of tendon reflexes, impact sympathetic outflow to vascular smooth muscle. Okay, this is when there is evidence of neurogenic shock, and absence of sphincter reflexes and tone. This is the phases of the spinal shock. We can see between like 1 to 3 days, usually patient will have this kind of presentation where patient may have areflexia or hyporeflexia, followed by initial reflex return, and you can start to see all the hyperreflexia 3 days onwards slowly until like full blown. You can see 1 week onwards. You can see all the hyperreflexias and spasticity later 4 weeks like onwards. So these are the phases for a spinal shock. So we are emergency medicine in ED. We usually see the earlier phase, the phase 1, when there is acute traumatic spinal cord injury. So remember that we don't see this full-blown hyperreflexia. What are the textbook description of the hyperreflexia, hypertonia, Babinski will be absent because patient will present with flaccid paralysis. All right. So let's come to this case scenario. This is a 37-year-old female teacher who presented with progressive bilateral lower limb weakness and numbness and weakness for 1 week duration. So initially she started Initially, it was started at the bilateral thigh with difficulty in climbing stairs. 2 days later, the weakness descended to both lower limbs and associated with numbness started from thigh downwards. Physical examination showed that she's conscious, alert. BP is normal, pulse rate normal, temperature also normal. Neurological high mental function was intact, normal, and cranial nerve closely intact, except facial nerve with features of mild bilateral facial muscle weakness. The result of potassium came back as 3.1 millimole per liter. She was treated as hypokalemic periodic paralysis because of the low potassium, and somehow there was slight improvement after the treatment. So, do we agree with the diagnosis? This is what happened because we don't localize the lesion, and we base something that more objective, like investigation for us. So, since potassium is low, so this is the tendency to blame the hypokalemic paralysis. But if we go thoroughly, actually, the lower limb examination shows that patient has all the features of lower motor neuron lesions, hypotonia, power of the upper limbs and distal part of the lower limbs is reduced. The proximal part of lower limb is more weaker compared to distal part. At the hips is 2/5 and 3/5 at the knees. Ankle reflex absence bilaterally. Plantar downgoing bilaterally. Sensation reduced. Okay, distal is more to proximal. So if we look back at this table, so we know that it fit the lower motor neuron. So we have the dark blue color. So which one of the features that actually fit well for the patient just now with the absence ankle reflexes or decreased reflex and symmetrical? They were based on this just now. Remember that they were mild facial nerve weakness. There were some element of cranial nerve involvement. So if you see here, actually, it fit well under the peripheral neuropathy, peripheral nerve. So, but what we know from this table that most of the weakness actually predominantly distal part. So these are among the few things that exception that happen in neurology, where in Guillain-Barré syndrome, the weakness is usually predominantly at the proximal part compared to distal part. So we see here, peripheral neuropathy in general, weakness and sensory loss is diffuse, bilateral, symmetrical, glove stocking distributions, a generalized areflexia or hyporeflexia, and weakness usually predominantly distal, but except for the GBS or CIDP, chronic inflammatory demyelinating polyneuropathy. So bilateral lower motor neuron facial weakness, and predominantly motor peripheral neuropathy is suggestive of Guillain-Barré syndrome. So these are the exception features in GBS that sometimes makes us confused to localize the lesions. Okay, so now let's come to another case. So this 25 years old Malay lady under background history of bronchial asthma, history of cough, fever for 1 week, and shortness of breath for 1 day. She was admitted and treated in the district hospital as acute exacerbation of bronchial asthma. Secondary to community acquired pneumonia. She was given antibiotic. During the admission in day 3 in the ward, she suddenly developed generalized weakness, and the lower limb weakness is more compared to upper limb weakness, and with the poor verbal output, she talked in words. She denied any sensory loss. She was referred to HUSM the next day with an impression of Guillain-Barré syndrome for further management because of the generalized weakness. So further history, she had history of hyperventilation, followed by weakness of all 4 limbs. She had this similar attack, almost similar attacks in August 2011. She is the eldest out of 5 siblings. She denied high risk behavior, working as a clerk, no family history of similar illness or epilepsy. Physical examination, she was rated, okay, pink, not respiratory distress, all the vital signs are normal. Cardiovascular, respiratory, and GIT system were normal. examination, neurological examination shows that all the basically cranial nerve intact, motor tone and reflexes were normal bilaterally, except for the power, reduced 3/5 in upper limb and 2/5 in lower limbs. Plantar reflexes were downgoing. So basically what we can see here, all are normal except for the power, where they were reduced in power in upper limb and lower limb. So which of these features that suit well in this table? So if we think of peripheral nerve disease, so there were no evidence of hyporeflexia or hypotonia. When we talk about neuromuscular junction, there is no evidence of fatigability from the history. Basically, so many things that we can see here that does not fit well. Basically, no pain or cramping, symmetrical or motor proximal, but this is like generalized. When we talk about, is it about talking anterior horn cell? Scattered like the motor. Is it from the spinal cord? So it does not fit any of the features in this table. So is there any other test that will help us to come into diagnosis? So actually we can do one of the tests, what we call it Hoover test. Hoover test is based on the principle of the cross extensor reflexes. So assume that the right leg is paralytic. So the Hoover sign is positive when the pressure is felt. In the paralytic leg when the non-paralytic leg is raised, and no pressure is felt in the non-paralytic leg when the paralytic leg is being raised. So like in this case, when you ask the patient to press down, so push down with your right heel, so you don't feel anything, no effect, because of the weakness, so-called like a weakness feel by a patient that patient has. So, but if you ask the patient to lift up the other leg, so you may put some resistance. However, you will feel that there are pressure or push down on the right leg. So when the pressure is felt and in the paralytic leg, so assume the paralytic leg is on the right leg, so you can feel that. You can feel that. Just now, when you ask the patient just to push down, you don't feel anything. But when you ask the patient to lift up another leg, you can feel there is a power on the so-called affected leg. So this can be done on the both leg if patient have bilateral paralysis, so-called like bilateral paralysis. So this Hoover test is basically tell us that the possibility of conversion disorders. Hoover test is high. It has the quite good sensitivity and high specificity. So when we did Hoover test, it was positive. So the impression during that time was conversion disorders. So she still referred to the neurological team for further investigation, admitted to the ward, and psychiatric consultation was done. On the next day, patient symptoms and signs improved, and patient was discharged well 2 days later. So conversion disorders actually is a functional neurological symptoms disorders, where it's a somatic psychiatric disorders involve neurological type symptoms that affect movement or sensation that can't be explained by a neurological disorders. So basically, neurologic symptoms do not confirm anatomically. It's atypical and do not correlate with the physical examination or neurological findings. It may start with a mental or emotional crisis and converts to a physical problem. However, symptoms or deficit are not intentionally produced. So this is not malingering. There is no secondary gain. There is no secondary gain. So this is not malingering. This is real conversion disorders because of the mental or emotional crisis that patient have these somatic psychiatric features. So when you do your physical examination, all will be negative. So this is very also partly important in ED, because otherwise you start to order everything. Of course, one of the investigation that will be ordered is your thoracolumbar X-ray, I can imagine that. And if all negative, then the next step will be like CT scan. There is very high likelihood. But actually, you don't have to do that. You can just do the Hoover test. Of course, from the good history, you can do the Hoover test, and you can narrow down the diagnosis and involve the neurological team and psychiatric team for further assessment and management. So this is my take-home message. Again, this is table for the localization in neurological emergencies. Again, we have these upper motor neuron lesions. We have these lower motor neuron lesions. I keep showing you this table because this table is very, very important for us in emergency medicine. From this localization, you know which site is involved, and you know what type of investigation that you want to order. Otherwise, you start to do everything. So the features as can be seen here. There are a few like hallmark features. Like example, like when we talk about the, of course, these are all specific features for that lesion, that disease in that particular locations. But some are quite obvious, like cross signs refers to the brainstem, sensory level refers to the spinal cord, and of course, bladder involvement you see here to involve. Like when we talk about cortex, yes, normal pterygocephalus also may involve with the bladder involvement, incontinence. But most of the time that you see, if you see like in the spinal cord lesion, definitely yes, will come with the bladder paralysis or bladder involvement. And remember just now, I told you that it won't be like urgency. That may be one of the features. Of course, it cannot become alone, because if urgency alone, it can be other things, other diseases, can be UTI, can be other disease from the GUS system. But if there is evidence of paraplegia and urgency, then you should think of spinal cord lesions. And you can see here all the low motor neuron lesions. There are a few things that are quite obvious here. The fasciculation is more prominent in anterior horn cells. Nerve root usually will have pain. Peripheral nerve disease will have the symmetrical distal weakness, but remember just now, Guillain-Barré syndrome, CIDP, proximal is more weaker compared to distal part. Normal growth distribution, hypotonia, okay, absence of the reflexes, fatigability in neuromuscular junction disease, and muscle disease may have pain, proximal weakness, symmetrical, cramping pain, normal or mild hypotonia. I think that's all for my presentation today. So thank you. So I end my presentation. So Hafizah, I leave it to you.
Thank you, Prof Kamarul, for the lectures given. Actually, just like a revision to me, I also encountered one patient, I think about 2 months ago, cardiac ischemia syndrome. She came with paraplegia and also incontinence. And from the, yes, it's important of taking proper history and physical examination in order to localize the lesion. So now, I would like to open the floor for any question to the Prof Kamarul.
Prof, Nasrina here, boleh dengar?
Okay, yes.
Okay, Hoover test, we do it for the lower limb. Any test to do for the upper limb that you know of? Because if let's say the lower limb has some limitation, the fracture, old fracture or whatever limitation, amputated whatsoever. So is there any test that we can do to the upper limb?
Okay, first of all, for the upper limb, the weakness usually is not that obvious compared to lower limb. Sometimes you can see inconsistency of the features. Patient may say weakness, but at the same time he can move his upper limb. That would be one of the features by simple observation, can give you some idea. But for the other test, that Hoover test for the upper limb, I'm not so sure. Maybe Dr. Hugh can answer after this. But yes, of course, this Hoover test seems to be more suitable in the lower limb rather than upper limb. But of course, you can see as overall inconsistency of the clinical features. He said weakness, but you can still the arm or the upper limb keep on moving compared to compared to lower limb, because lower limb usually patient has to lie down on the bed, so you don't really see obvious any movement compared to upper limb.
Okay, thank you.
Any more question to Prof Kamarul? If you shy to speak up, you can put in on chat. For Nasrul Hadi, actually, this session is recorded and will be uploaded in the Facebook of Neuroemergency Medicine and also in the YouTube channel also. Sorry, any more question from the floor? Actually, if no more question, on behalf of everyone here today, we would like to thank to Prof for your time to speak to us. Hopefully, we will have another lecture by you in the future. Prof, thank you.
Inshallah, inshallah.
Thank you.
Thank you. Okay, then I think it's time for us for second lecture.
Fiza? Fiza? Hello, Fiza? Fiza?
Yes, Nina.
Okay, let me just stop recording, then I record again so that we'll have two separate sessions. Just
Okay,
hold on,
okay.
Okay, wait,